So, um, so thank you. Yeah, I think, I'd be happy to answer questions during. I'm not like seeing the chat screen right now, so I wouldn't be able to see it, but feel free to, interrupt, David, if that works during this. Usually, if I'm giving a talk in person, I'm happy to have people ask me questions throughout the talk, and then I can also answer questions at the end as well. But yeah, I am a neurologist, and I was in clinical practice for many, many years, did clinical research throughout my career, and more recently have moved into solely doing clinical research trials. I find it really fulfilling. Still get to meet with patients and get to identify good clinical trials for people to be involved in any all different areas of neurology, and particularly obviously today I'll be talking about our epilepsy trials. And about epilepsy in general. But it's been, really nice. The past couple of years, I've been working at Boston Clinical Trials in Roslindale, and just being able to focus completely on clinical research and trying to find cures for some of the neurological diseases that we have out there. So it's been very fulfilling. Okay, so I'll get started. I'm sure there's many different people that are a part of this group, and some may have recently been diagnosed. Some may know somebody or take care of somebody that has seizures. So, I don't want to spend too much time, going through, what are seizures and what is epilepsy. But I figured that everyone might be coming from a different place, and I thought it might be good to just kind of start there before we talk about research. So first of all, what is a seizure? So seizures are sudden temporary bursts of electrical activity in the brain that change or disrupt the way the messages are sent between the cells in the brain. This can cause an involuntary change. It could be a body movement or function, could be a sensation, a change in behavior or awareness. And basically, all of us have the potential to have a seizure. I don't necessarily have the numbers, but I think, it's very common for somebody to have one seizure in their life. Um, so what happens after a seizure, sometimes, it can take people several minutes to hours to kind of get back to their baseline self. They may feel tired, weak, confused after the seizure. And again, a seizure in itself may happen only once and never occur again. So if I were to see a patient, and frequently, like kind of common story is maybe a college student who stayed up all night studying, and they experienced a seizure, like a generalized tonic-clonic seizure, which we'll talk about the different types in a few minutes. And it was probably, due to that lack of sleep. There could be all different reasons for developing, having a seizure. It could be low or high, very high blood sugar, changes in electrolytes like sodium or calcium or magnesium levels. Other metabolic causes can contribute, like if somebody has kidney disease or liver disease. Even in eclampsia, when somebody's pregnant and develops eclampsia. So that could be like kind of a one-off situation where they just had a seizure, something kind of provoked it to happen, and then never occurs again. And as a neurologist, we would ask questions, get some background, their medical history, their any family history of seizures, what may have provoked it, may do some imaging studies, to work this up. And then with one seizure, we may not, the general consensus is to not necessarily treat that person because if we think that it's likely to not recur. So that's seizures. But what is epilepsy? So epilepsy is recurrent seizures. So this is somebody that has had more than one seizure. Sometimes even with two seizures, sometimes we as neurologists may not necessarily treat somebody, but if it's getting to be more than two seizures, then we would consider it epilepsy. And people with epilepsy have a lower seizure threshold. That is, they're more likely to have seizures in any given situation. Just to give a little bit of numbers, it's reported as the fourth most common neurologic disorder in the world. There's probably 50 million people worldwide that have epilepsy. And in the United States, about 3.4 million Americans with epilepsy. It's not one condition. There's many different types. It can affect all ages, ethnicities, races, gender. There's really all different types of situations with epilepsy. And the impact on the person really kind of depends on the type of seizures that they're having, the frequency, the severity, the area of the brain involved, what's the underlying cause. Is there a structural abnormality, and how do they respond to treatment? So all of those things can impact how they function. So some people with epilepsy may have convulsions, sort of a motor, involuntary motor movement. Some may lose consciousness. Others may simply stop what they're doing, have a brief lapse in awareness, a staring spell. There's a wide variety of different presentations with epilepsy. Some people may have a seizure very rarely. They could go years without having another seizure, and others may have hundreds of seizures each day. So who is more likely to have epilepsy? Well, probably half of people with epilepsy don't have any known cause, at least so far in our diagnostic, testing, and our ability to sort of figure out what the cause is. 50% of people may have no cause found. But possible causes can include genetic factors, and it's reported that there's probably hundreds of different genes that may be playing a role in epilepsy. There could be an underlying developmental brain abnormality, so something that you were born with, developed in utero. It could be from an infection. So somebody comes in the hospital with encephalitis or meningitis, could go on to have epilepsy. TBI is traumatic brain injury. So any traumatic brain injury or a stroke can cause some scarring of the brain tissue, and then that could be a focus for developing seizures going forward. We always look, at imaging studies for things like these, as well as a brain tumor, any other structural lesions like arteriovenous malformation, which is an abnormal conglomeration of blood vessels that could cause seizures. Other things, more general things like, alcohol or alcohol withdrawal can lead to epilepsy. Alzheimer's disease is another example, where somebody could develop seizures from Alzheimer's. That's not always the case, but in some patients that have Alzheimer's may develop epilepsy. So what are the different types of seizures? Just generally, there are most commonly people have focal seizures. So focal seizures means that it's starting in one area of the brain. It could just stay in that area of the brain, or it could go to here, what I'm showing here, focal to secondarily generalized seizures. So it could start in one spot and just stay there. But then in some people, it could then go on to not just be in this abnormal electrical activity in that one spot, but then kind of spread across the brain over to the other hemisphere, and then you have a generalized seizure. So examples of a focal seizure could be a feeling. A very common one that I hear a lot is déjà vu. And many people, have experienced this sensation of deja vu. And I wonder, if is all of that some sort of focal seizure or what, what is that? But it's a very common complaint in people with epilepsy is to have this sort of this feeling of deja vu. Other examples, like a sudden unexplained joy, anger, sadness, nausea, hearing or smelling or seeing or feeling things that are not there, that kind of comes on very suddenly. It could be an involuntary movement of one part of the body, like suddenly their arm, starts to shake. So those are all kind of examples of focal seizures, and that's sort of what most people with epilepsy have focal seizures. The other type of seizures are primary generalized. So those are the seizures that sort of start in both hemispheres at the same time. So both sides of the brain at the same time. One example is something called absence. This is commonly most commonly found in children, young children, and can be misdiagnosed for quite a period of time. It's sort of a staring spell, but it's very quick and it could happen multiple times a day. So oftentimes, a teacher could notice that the student is not really paying attention very well, but otherwise you might not notice anything else. Sometimes they might have some eye blinking with it or something else that would give you a sign that it looks like a seizure, but it can be very hard to identify as a seizure. Other types are tonic. This is kind of a general stiffening of the body. And I'm sorry, that was misspelled there, but that should say clonic. So that is more of the this kind of back and forth movement of the arms and sort of a shaking movement is a clonic movement. And if you put those together, you can have a generalized tonic-clonic seizure, which used to be called grand mal seizures. So this is sort of what most people think of when they think about epilepsy, is because it's so striking, is a generalized tonic-clonic seizure. Other seizures are myoclonic. This can be sort of a sudden jerking movement. Like you have something in your hand and your hand kind of, flings out the glass that's in your hand, let's say. That's a kind of a myoclonic seizure. Atonic seizures means a kind of a lack of tone. So it's sort of like a drop attack, or, sometimes it's called, where either the head slumps down or the whole body just kind of drops. And that can be difficult because the person could get injured from that happening. So those are sort of generally the types of seizures. What do we do when somebody comes in for, goes to either their primary care physician or to their neurologist or to a neurologist to get a workup for seizures? We take a medical history, try to find out all the details of what exactly happened to see if it sort of sounds like it's a seizure or is it something else that might look like a seizure. We get a family history. We do a physical exam. We do a neurological exam looking for anything that would suggest any kind of structural abnormality in the brain, differences in tone on one side of the body or the other, or weakness on one side of the body or the other, or things like that. Then if there is a suspicion of seizures, we could do an EEG. I wrote here EEG LTM, which is sort of long-term monitoring. So when we're really trying to figure out, and some of you may have done this, where you actually come into the hospital and are monitored off of your seizure medications for a few days to sort of figure out where is the focus of the seizure, or to just diagnose that someone has seizures. So an EEG will monitor the brain waves in your brain, and if we see any, abnormal electrical activity, that would be suggestive that they're having seizures. And even, taking it a step further, if there was really a plan to figure out exactly where the focus was, sometimes people have a surgical placement of electrodes, and we monitor them in the hospital setting to monitor for seizures, especially if we maybe couldn't see it quite as well with just surface electrodes on the scalp. So that's another way. And then we monitor for a few days until some seizure activity happens, and then they can go back, to the operating room and have those removed. Other parts of the workup are neuroimaging. We want to see if is there any structural abnormality with a CAT scan or an MRI that could be causing the seizures. Sometimes people do a PET scan looking for, abnormal activity, metabolic activity in the brain, or SPECT scans. Not as commonly done, but those may be done as well. We will also look at blood tests to look for anything that could have, as I alluded to earlier, is there some metabolic cause for the seizures? Anything else that we could potentially treat. So current treatments, there's many, many seizure medications out there. Probably over 30 different options are out there. And, ideally you go on your first seizure medication and it really works for you and you don't have seizures ideally for years or ever. Sometimes, that doesn't work. We start off on a low dose and ramp it up. We try to go with one seizure medication, but sometimes, an additional seizure medication needs to be used. And then it gets more complicated because then we're looking at interactions between the two medications. We're looking at potentially more side effects. So it's nice that we have a lot of different potential options. But, still it can, for some people, it could take multiple different combinations to try to figure out how to reduce the frequency of their seizures and the severity. And if seizure medications are not working, some people go on to surgery. If you can find one focus that's causing the problem, that might be a potential area to kind of remove that area of the brain to stop the seizures from happening. The problems potentially with that, or, that either it might not work, there could be more seizures after that. It's one sort of treatment, but it's not necessarily perfect. There's other potential treatments, neuromodulation. So this could be vagal nerve stimulators. So I've had some patients that a vagal nerve stimulator can be really helpful in addition to, taking their seizure medications, to really reduce the frequency and severity of their seizures. There's responsive neurostimulation, and so this is a newer modality that can kind of monitor for an impending seizure, and may be able to help in terms of treatment of the seizures. Deep brain stimulation is another potential option. Again, these are all kind of in people that the medications, that they've tried have not been working. I throw out there a ketogenic diet. Some people will try that. That can be very difficult to stick to and to make sure you're getting the right nutrition and all of that, but can be helpful in some people for reducing their seizures. And the goal, of course, is be free of seizures or at least improve, your quality of life. So I just put this up just as a general thing of living with epilepsy. It's not just, anti-seizure medications, it's other treatments that I mentioned on the previous slide. Healthy habits can be really important and make a big difference. So, in particular, if you have epilepsy, watching your sleep and really trying to get best sleep habits. It's on the same time of the night, getting to bed, making sure you're getting at least 7 hours of, roughly 7, 8 hours of sleep, whatever, helps you so that you're not triggering your seizures. Stress management is really important. Adhering, of course, to your medications, which I know can be hard, especially if you're having side effects with them. But it's really important to, keep taking your medications. Really, the number one reason for developing something called status epilepticus, which is when somebody continually has seizures, and this goes on for at least 5 minutes, could go on for hours. that the number one reason is stopping your seizure medications. And when that happens, you end up coming to the hospital. We end up putting a breathing tube in to help with your breathing. It's very involved. And, of course, we want to try to avoid that. So medication adherence is important. Know your triggers. When they did a survey of people with epilepsy, the number one trigger that was noted was stress. So again, as I said in the previous line up here, stress management is really important. Watching, alcohol intake, avoiding dehydration, missing meals can be a trigger, illicit drugs, hormonal changes, particularly in women, depending on where they're at in their menstrual cycle, can be a trigger for their seizures. I already mentioned sleep deprivation, can be a trigger. Flashing lights or moving patterns can be a trigger. So there's a number of different triggers, and you just, need to kind of look at what things seem to set off your seizures so you can try to avoid those things or mitigate them. Many people have what's called an aura. So recognizing that you're having an aura, because that is a focal seizure. So that could be that deja vu feeling. Some people describe a rising feeling in their stomach. There's all different types of auras. And so it can actually kind of be helpful to have that because it's a warning and you can kind of get yourself away from a situation that you could get hurt. Like, let's say you were driving and you needed to, kind of pull over and get off the road, or other situations. So that can be useful to look at. I just mentioned here seizure first aid. So, for those of you that may be a family member of somebody with epilepsy, just trying to kind of keep things away, especially like somebody that's having a generalized tonic-clonic seizure, keep things out of their way so that when they're having these movements, they're not getting hurt. Turning them over onto their side in case there's, any vomiting or anything else so that they're not choking. Just making kind of a, sort of a safe area for them. I just highlight here driving concerns, at least for, I don't know the laws in every state, but in Massachusetts, as neurologists, we tell our patients that if they've had a seizure, they need to not drive for 6 months. And that the onus is sort of on the patient to report to the DMV about that they have had a seizure. If they can be treated and remain seizure-free for 6 months, then it can be they can be allowed to drive depending, on all the different circumstances of their seizures. So, and other, issues are, of course, it's very key to have support from family, friends, this kind of, support group. They can make a big difference in somebody living with epilepsy. And then at the bottom here, I put having a neurologist, or even specifically, because there's general neurologists, and then there's epileptologists. So they are, specialists in seizures and epilepsy, and it could be helpful at least once to see a seizure specialist. And I know that can be hard to get appointments, and maybe your seizure could mostly be managed by your primary care physician, but at least try to once go to a neurologist or epileptologist. And I just put here, some of course, this group and the Epilepsy Foundation. There's a lot of great resources online. I came across Epilepsy Alliance America. The American Academy of Neurology has a nice magazine that Brain and Life that it's not just epilepsy, but it's got a lot of great information for people with different neurologic disorders, including epilepsy. And then I put on here clinicaltrials.gov. So if you're looking for research trials, you want to find out a little bit more about a particular research trial, you can go on to that website, because every research trial clinical research trial in the United States has to be registered with clinicaltrials.gov. So it will give you information about the study, where are they doing, where are the sites for that particular trial. You can just put in a keyword of epilepsy and you'll get thousands of different things. You can narrow it down with some other words, and find out what's out there. So it's another potential resource. This is not an exhaustive list. There's obviously many more organizations that you could look up online. Okay. So now I'm going to just shift to why clinical research matters. All of these, I mentioned earlier that there's at least 30 different seizure medications that have been FDA approved. Well, how did they get to that point? It's from research volunteers. By doing clinical research, we're able to discover better treatment options. Can we find something that, like the current medications don't necessarily work for everyone? They may have side effects. We're always looking for something that better. And the only way we can get to that point is by people volunteering to be a part of a research trial. That your participation actually shapes the future care for people living with epilepsy. Thousands of, not just in epilepsy, but all different kind of different indications and diseases, all in the past, whether it be medications, surgical options, device trials, all of these things only got to that point of being approved after years of clinical research and through the participation of research volunteers. So even if the treatment may not directly help you, your involvement can help many, many other people. So what is the latest in epilepsy clinical research? So I mentioned earlier that I work at Boston Clinical Trials, and these are some of the studies that we have going on right now. This study is by a company, Praxis. That's the sponsor for the study. And this is a study looking at an oral medication. So it's a once-a-day medication for people with focal seizures. So if you have a primary generalized epilepsy, you would not be able to be a part of this particular trial. But this trial is for focal seizures. And it's what's involved are about 10 different visits over the course of about 23 weeks. So what does that break down to? For the first 9 weeks, up to 9 weeks, there's a screening process. And what that can be is, and I'm going to talk about what is involved with a visit. So I'll get to that a little bit more later. But part of that screening could be keeping a seizure diary to see whether you would qualify, for this trial. After that period of screening, then you would be taking a medication for 12 weeks. And then, in a double-blind fashion. So meaning that you wouldn't know whether you're taking the study medication, right there I wrote IP, which means investigational product. You don't know if you were taking that or if you're taking placebo. So there's 12 weeks of treatment. You still can be on the seizure medications that you're already on. And then there's 2 weeks of follow-up. And then that's the end of the study. You have a 1-to-1, ratio of whether you're on the study drug or on placebo. But then after the trial, they offer you the option of what's called an open label extension. That's what the OLE is here. So the open label extension, sorry, I'm trying to circle here, is then that you're on the study drug. And that could go on in many studies, that can go on for a year, 2 years, longer even, until the sponsor receives FDA approval for that medication. Or if they found that the medication was not effective, then the open label extension would stop. So that's, sort of the nice option that, only the people that are participating in that double blind trial then can go on to the open label extension. So who can participate in this particular trial? Anyone ages 18 to 75. You have to have four or more seizures a month, and take one up to three anti-seizure medications. And there's other criteria, but that would be sort of assessed during the screening visit. So this particular medication works on one of the channels that in the brain that help regulate electrical activity. So many seizure medications could work on the sodium channel, and others work on the potassium channel. This one it works on the sodium channel, and the thought is that it can reduce it's more targeted, and it can reduce the potential side effects, and have, still have better seizure control. But that remains to be seen. So this is an investigational medicine. This is, has to be proven in this trial. Earlier phases of this trial have been positive, and that's why they're still going on with this trial. That's one trial that we have going on, and I can answer questions later about that. The other sponsored trials are with Biohaven, and this is called Biohaven 7000. This is also for focal onset epilepsy. With this trial, this is targeting the potassium channel in the brain cells that regulate the electrical signals. This is also a once daily oral medication. This one, for this study, you have sort of a 2-to-1 chance to be on the investigational product, either at a high dose, a low dose, and then the other third of people are on placebo. It's what to expect are about 6 visits and 18 weeks. There's an up to about 8-week screening period. Then there's 8 weeks on the study, medication or placebo. Again, double blind, in order to be able to tell whether it really is effective or not. We have to do that in a research trial, so that I don't know whether you're on the medication, you don't know whether you're on the medication. And then after that period of treatment time, there's a 4-week follow-up period. For this trial, who can participate are anyone ages 18 to 75, so very similar to the other trial. You have to have 4 or more seizures a month, have been unsuccessful with at least 2 anti-seizure medications, and then there's sort of other criteria here as to how many seizure medications that you take. So again, this one's focal onset epilepsy. There is also for this trial an open label extension option as well. I'll get to that in a moment. And using the same investigational product, there is another trial by Biohaven that is for people with generalized epilepsy. Idiopathic means somebody that we don't know what the cause of their seizures are. So somebody that, say, has a brain tumor and that's why they have seizures could not be in this trial. But if there was no particular cause found, then you could potentially qualify for this trial. This trial is 10 visits in 23 weeks. There's about 30 days of screening, up to 30 days of screening. You could be at a maximum of 24 weeks on the study treatment. And then you could roll over into an optional open label extension where you're on study treatment. And then there's a safety visit at the end. For that trial, it will, if you have a second generalized seizure during the trial while you're on the treatment phase, then they will stop the treatment, the double blind treatment, and then you could go over into the open label extension phase earlier. So that is kind of summarize that trial. Same age range, 18 to 75, 4 or more seizures a month, at least 3 days with a generalized seizure in the past 4 months, have been unsuccessful with at least 2 prior anti-seizure medications. And of course, there are other criteria as well. So that is that trial. And then this slide is just showing that there is also the open label extension. This is the number for the open label extension for that 303 trial, which was the Biohaven trial for focal seizures. I don't know what the number is for the one for generalized seizures. I don't have that one listed on this slide. But basically, all of these trials give you that option. So that's sort of one of the things that, people find as a positive thing that, if I do the trial, the double-blind trial, I at least have that option of going on to the open label extension. So what is the potential value of research for research participants? One of the things is access to an extra layer of healthcare. So besides going to your primary care physician or your neurologist, you're also meeting, with someone like myself. For these particular trials at Boston Clinical Trials, you would be meeting with me, some of our other medical staff. We have other physicians, research coordinators. And we watch you closely throughout the duration of the trial. So you get that extra layer of healthcare. You get access to treatment options for years before they're available to the general public, because it takes years to get to that point where they can get FDA approval and be able to put the drug on the market. You received focused attention and monitoring from these medical experts. You may learn more about your disease. You get a lot of free medical services through the clinical trial, like whether it be something, diagnostic testing, the study medication, and other medications. Other potential values that people find are just intellectual interest. Some people feel, a psychological boost by being able to feel like they're taking control of their disease and knowing that they're contributing to other people, with epilepsy. And again, it's kind of altruistic, the benefit, thinking of the benefit of others and the advancement of science in general. And then I would just comment that, because a lot of people ask about, do I need insurance? No, you don't have to have insurance for this. There is compensation for every visit throughout the study. Rides to and from Boston Clinical Trials are provided. So there's all of that's included. And to mention on the safety of doing clinical research trials, every research trial that we're involved in go through what's called an institutional review board, or an ethics committee, and they review the study protocols in detail, all aspects of how the study is conducted to ensure that it is safe for the participants. Also to ensure that what's called a consent form is very clear for the participants about what are the potential benefits, what are the potential risks, what exactly is going to happen in the study. All of that has to be outlined very clearly in that consent form. There's also study monitors who are known as clinical research associates. They make sure that we, as the research site, are following all the study protocol procedures and following all of the federal regulations that are out there throughout the entire conduct of the study. Your safety throughout the study is the highest priority. Throughout the study, you're always going to have someone, if you had questions or concerns, either you'll talk directly with me or you'll talk with one of the research coordinators or one of my colleagues, if there's any questions at all during the study. And finally, participation is voluntary. So even if you're signing a consent form saying that you're willing to do this study, at any point in time, you could just say, look, I don't want to do this. And then you can just withdraw at any point for any reason. And then just to mention there at the bottom, there's all kinds of standards that are maintained to keep your privacy maintained throughout the study as well. So this is what I mentioned earlier. I just wanted to, I'm pretty much done with the talk, and then I'd like to take some questions as well. But I just wanted to mention, what can you expect with the research trial? Because, many people, have never done a research trial before, and they really have no idea what to expect. So the first thing is, let's say you were interested, you would give us a call at Boston Clinical Trials. We would have somebody that would talk with you on the phone, take a few different demographic information, maybe ask you a few questions to sort of see what trial might be right for you. And then if everything looks good at that point, we could schedule a screening visit. With the screening visit, you would come in, um, you would, um, you would, one of the coordinators would kind of meet with you, give you what the consent form. You could meet with me or the coordinator to ask any questions at all. Sometimes, we have people just kind of go home with the consent form to look at it. They want to talk with other family members or, friends before they decide. But you review that in detail. Ask any questions that you want. And then once you've signed the consent form, we give you a copy of all that because it has everything really you need to know about the trial, when the visits are, how much compensation for each visit. It has all of those details. And what the time frame is for the trial. Then at that point, you would meet with me or potentially one of my colleagues. I would go over your medical history, in detail. We talk about what medications you're on. I'd go over I have I and E criteria, that's inclusion and exclusion criteria. So going over everything that we can to see, would this trial be a good fit for you? Then you might have, depending on the trial, you might have vital signs done, a physical exam, a neurologic exam, potentially. There may be questions, like sometimes they're on, questions that are on a tablet that we have you go over. We might give you a diary, as I mentioned, especially for these particular trials. There'll be a diary that you would, have at home and follow whether, record whether you've had a seizure that day or not, and what kind of a seizure and all of that. Other things we do are, EKG, blood tests, in some cases we might need some medical records, just to kind of confirm that you have a diagnosis of epilepsy and all of that. Then there's a screening period. So then this is when you're at home, keeping your diary, we talk to you periodically, make sure we have everything in place that we need. I'll, let you know if there's any abnormalities or any concerns with your laboratory tests or anything like that. And then if everything goes, well, at that point, then you would come in, you'd be scheduled for a randomization visit. Randomization means flip of a coin. We don't know which treatment you're going to get. Are you going to be on the study medication or on placebo? So that's what that visit is. That's when we do some more, vital signs, your exam, things like that, and then you start taking the medication. And then you'll go home with the medication going forward. And then we monitor you, talk to you by phone, have you come in, to talk with me. And see how you're doing with that. We follow your diary to see how are your seizures frequency doing and all of that. So we're monitoring you very closely to make sure everything is that everything is safe and it's effective and and all of that. And then you reach the end of the study, and as I said, then you get into the option of whether you would want to go on to the open label extension, the study of another study. So that kind of summarizes that. I just have a slide here. Boston Clinical Trials is one research site. We have all different kinds of trials there, not just neurological trials and epilepsy trials, but that as a neurologist, I'm of course most interested in the neurology trials and epilepsy trials. But we are one site. We have another site in Methuen. And then we have sites across the country, and they're all part of what's called Alcanza. It's a site network organization. This map actually is dated. We have some further west than here, so we have probably over 20 to 25 sites across the country. And then finally, I just wanted to show this slide. This is how you would get in touch with us at Boston Clinical Trials, the phone number. You can scan this QR code, and then it should lead you to a couple of questions. If you fill that out online, then you'll get a phone call back from us. And that could be the start of kind of seeing whether you would want to schedule a screening visit. And that's where we're located in Boston, technically Roslindale, Mass. And yeah, so that's kind of all I was going to present today, and I'd be happy to answer any questions that you may have. Perhaps I should stop sharing at that point.
We haven't seen any questions come through the chat, but Dr. Green-LaRoche, thank you so much. Yeah, if anyone wants to unmute and has a question, wants to ask it that way, go for it. And if not, perhaps it was just a perfect presentation. Lisa, you have a question?
Oh, good.
Yes.
Good question.
Can anyone join the clinical trials at any time? Are you actively looking for participants right now? Or
Yes,
is it
those
a
studies.
window of time? Yeah.
Yeah, those studies that I mentioned are all enrolling. The generalized, I should say that the generalized epilepsy one, they've just put a temporary pause on enrollment. That could change any day. I don't know on that one. But all of the other ones are currently right now actively enrolling. And it's hard to predict how long, it takes to enroll. A lot of these studies, they need like over 200, 300 participants. We are just one site that's participating in these trials, but these are these are multi-center trials going on across the country. And sometimes enrollment's faster, sometimes it's slower. So sometimes it could take a year, 2 years. I don't know. And I'm not sure. I would say for these particular ones, it's going to be probably at least another 2 or 3 more months of enrolling.
Excellent. Thank you.
Yeah, sure. Please ask me questions. I enjoy answering questions. So if anyone has anything that you want to ask.
And you might have touched upon this, but I want to just sort of reemphasize, if not, around costs associated with, patients traveling to sites in terms of like reimbursement and sort of what that might look like.
Yes. So we, particularly at Boston Clinical Trials, we use Lyft. So we have a contract with them. So we can have them, come right to your house and bring you in and bring you back. So that it kind of takes away like the worrying about driving in, or if you're not able to drive, you don't have to worry about that. So that's taken care of with any of our clinical trials. And then for each visit, there's a stipend. It's not, a huge stipend, but it's just to kind of compensate for your time. If it's going to be a very extended visit, I would say with some of our studies, we, can provide, lunch, sandwich or something like that as well. If it's a very short visit, that's, that wouldn't be the case, but, sometimes it can be a longer visit for whatever reason, and that can be provided as well.
Excellent.
Mhm. But we do have parking too. So like if you did want to drive, you can also do that. But it's just an option that if you, and I think a lot of people take advantage of that because it just makes it easier with traffic and everything. You don't have to be the one driving.
Yeah.
I have another question.
Mhm.
So if we did want to, check this out and see if this is going to work out, is the next step to just call you straight, or should we talk to our doctor and have them contact you, or what's the next step?
That's a great question. So, yes, you should call the number that I gave, and I can put that back up in a minute. But Boston Clinical Trials is the name of our site, and you can talk to someone to schedule that first screening visit. But I always tell my patients that you should also be letting your doctor know. If it's like for this like an epilepsy trial, it could be either the primary care physician or it could be the neurologist. And I always like, them to kind of let them know so they have a heads up that this is going on. But they don't schedule it for you. You have to kind of go directly to our site, and to set up the appointment. But generally, I like it, the physician, is fine with it, or if they have a concern, they can reach me directly, and if they want any information, I can provide a little bit of information about the study like I presented today, so they have some idea about it. The nice thing about these particular epilepsy trials is your medications don't need to change. So what you are, because with some trials, you might have to come off of medication and try, to try it, but this is not the case with these epilepsy
Excellent.
trials. These are, you continue kind of on what you're on, and this is, but you're maybe not getting enough benefit because you're, say, having 4 seizures or more a month, then, then this is in addition to that.
All right. Thank you.
Sure. Yep. And and along with that, like sometimes because we do a lot of monitoring, blood tests and other things that, if there was any abnormality with that, I would then get that information to the participant and, and encourage them to let their physician know about it and follow up more, with them. Because again, it's very, very frequent monitoring and more than you would, kind of have in just your regular clinical, dealings with your primary care physician or your neurologist.
Thank you.
Sure, you're welcome.
It's great to hear that patients would continue their current medication, because I imagine how troublesome that could be if you are forced to come off your medication and then end up on the placebo. Off your regular meds. So that's great to hear that you continue your regular medication too.
Yeah, and one of the things I find with these particular trials are fairly short, and so it's, you don't have to be on that double-blind treatment phase for very long before knowing that you're on the study medication. So that's kind of a nice thing too. Some studies last much longer than these do. So it's kind of short duration, and then if, then you have that option.
That's great. Well, I know we're nearing our end here, and if folks have any additional questions, feel free to reach out to us at Epilepsy Foundation New England. And if we don't have the answer for you, we can certainly connect you with Dr. Green-LaRoche, who can help answer that, or someone else on her team. But Doc, thank you so much for your time this evening. This was terrific. And I know I really enjoyed it, and I hope everyone else on the call did as well.
Great. Thank you. Thank you for allowing me to be here.
Of course. Well, with that, everyone, I hope you have a great evening.
Great.
Thanks so much.
Thank you, everyone.
Bye.